our next speaker is Dr. Spruha Dholakya. She is going to give a detailed insight on how do I give blood transfusion. She is she is assistant professor in AIMS. She was a medical director in a reputed life blood bank. She is a member of various blood transfusion societies, and she is also author of various articles in index journals. Over to you, Dr. Spruha.
Thank you so much, sir, for the introduction. At the outset, I would like to thank the committee for giving me this opportunity to discuss a very brief about blood transfusion, how a clinician should give a blood transfusion. So to begin with, being in transfusion medicine since almost a decade, the first thing which I always start with is our own blood is still the best possible blood in our veins. So to initiate the concept of patient blood management, this is the first thing which I would like to deliver. The era gone by, Amar Akbar Anthony, many other movies have shown us, but we are not into the era. We are into the era of component therapy. Not even whole blood, but components. So what are these components? We all know when we centrifuge the blood, depending upon the specific gravity of its components, they get separated into a refrigerated centrifuge as plasma. The middle layer contains white blood and platelets, and the lower layer contains pegged RBC. So we will briefly understand today what are the indications of blood transfusion. Of course, most of us know better than me maybe. Learn pre-transfusion preparation steps, master the transfusion administrative process, monitor patients effectively during transfusion, and recognize and manage transfusion complications immediately. So as we all know, as I told, we are in a component therapy. So when to transfuse? There are certain restrictive thresholds which are laid out now by even WHO and National Blood Transfusion Council of India. And these are, as far as packed red blood cells are concerned, of course, to increase the oxygen carrying capacity of the patient. If the hemoglobin is less than 7 gram per deciliter, yes, in cardiac patients, it goes up to 8 gram per deciliter, and in case of acute blood loss, if it is greater than 15%. When we are talking about platelets, less than 10,000 per microliter, irrespective of any bleeding diathesis, prophylactically is advised. Less than 50,000 in case of any surgical procedures or bleeding. Plasma, that is fresh frozen plasma. Coagulopathy, if it is defined, INR is more than 1.5. Massive transfusion, we sometimes call it as a massive transfusion protocol. Cryoprecipitate. The use of cryoprecipitate is very specific. In a patient who is in DIC, disseminated intravascular coagulation, and also a patient of cardiac and renal disorders also, cryoprecipitate can be will have one hand above than fresh frozen plasma. In normal cases, it is given in hypofibrinogenemia when less than 100 mg per deciliter is the value, or in von Willebrand disease or Christmas factor deficiency. So how do we prepare our patient for transfusion? Physician order and patient consent. The first and foremost, the patient consent taken on day 1 stays valid for 7 days. Most of us mostly will be knowing this. We will be verifying the patient blood group and the cross-matching slip. Blood grouping compatibility as far as ABO and RH is concerned. IV access has to be secured, 18 to 20 gauge is preferred. Specific equipments like blood administration set, normal saline infusion pump are the prerequisites. So ideally, in order to verify any blood product, we would suggest not a single but 2 healthcare providers should do that. Patient name, ID number, blood unit, expiry. Sometimes we get queries from clinicians telling that platelets which you have issued are expiring today. The day of collection of platelet is considered as 0 day. So if at all you are getting a platelet at around 10 a.m. on the day of expiry, that is 5th day, it means your platelet is getting expired at 12 midnight. And even Western studies have shown that even for 7 days the platelet remains in good viability if at all they are stored in good conditions. Compatibility labels has to be checked and blood time checked before the transfusion to avoid any technical errors. So just a brief about how the prerequisite check about blood transfusion is carried out. Initially, all the paraphernalia which you will be required in beginning the transfusion process
Welcome
will be
to the administration of blood transfusion. This video will show you how to safely administer a unit of blood.
So, temperature, pulse, BP, respiratory rate, all are mandatory checks as far as the initial transfusion process is concerned. This is the blood transfusion reaction record and patient monitoring sheet. These are the paraphernalia you will require: a blood administration set, gloves, the blood bag which your patient is supposed to get. There will be a compatibility slip issued from the blood bank and the swabs. After getting all the paraphernalia ready, we should cross-check at the bedside of the patient whether the blood bag which is received by the hospital or bedside is exactly matching the patient credentials. So, double check, as I told, is mandatory. Administering the transfusion, initially we will prime IV with normal saline. We will connect our blood bag with a filtered administration set. We will start infusion slowly. Initially, first 15 minutes is the key. For first 15 minutes, the infusion should start very slowly, whether it is red cells, platelets or plasma. My vital signs, as I told, for initial 0, 15 and 30 minutes is mandatory. After that, every hourly we can check. Ideal transfusion should continue for not less than 4 hours. Monitoring of the patients, we all know TPR BP, that is vital signs. Symptoms: fever, chills, rash, dyspnea. There is a regime at certain hospitals or clinics where they give IV anti-allergics before initiating the transfusion. But as a transfusion expert, we would request to refrain from the practices because there are various minor reactions which will be overlooked or which will be masked if at all any anti-allergic is given pre-transfusion. Documentation, of course, mandatory. All the documentation has to be monitored and documented. So, how we will recognize the transfusion reaction? There are various, it's a horizon of transfusion reactions and we are not here to discuss all of them. But yes, immediate transfusion reactions can be acute hemolytic type of transfusion reactions, febrile, non-hemolytic. Febrile, when I say, is when pre-transfusion temperature of your patient is raised to 1 degree. During the transfusion, we call it as a febrile non-hemolytic type of transfusion reaction. TRALI, we all have heard about, that is transfusion related acute lung injury. Of course, the first and primary management is to stop transfusion, notify the blood bank and the supportive care. So, what we will do if at all we encounter a transfusion reaction?
When your patient shows signs of an acute...
So, what we should do? The first thing, as I told, we are stopping the transfusion. keep the IV line open. Sometimes, sometimes we have seen that patients are, because of looking at the BT, they are a bit agitative. So, you can always stop, give time and then restart if at all it is only a patient side issue. Then you have to check for airway, breathing and circulation, check for the body temperature, oxygen saturation, blood pressure, heart rate and urine output. In case of emergent hemolytic transfusion reaction, you might encounter hematuria in the urine. Check your blood product and labels with the compatibility slip which you have received from the blood center. And even if the discrepancy is not found, after keeping IV line open, inform the blood bank regarding what has happened to the patient, at what time the transfusion was started, at what time it was stopped, and for what reason the transfusion is stopped has to be mentioned in your transfusion reaction reporting form. After that, you have to collect from the other hand one sample in EDTA, one sample in plain, urine sample and the blood bag with transfusion set in situ to the respective blood bank or a blood storage unit where you have received the blood bag. So, as I started my presentation from patient blood management, I would also finish it with patient blood management. So, what is basically patient blood management? Is to optimize transfusion use. And how we can do that? Use restrictive transfusion thresholds rather than liberal. So, hemoglobin cutoff should be less than 7 gram per deciliter. Consider alternatives like ion therapy or erythropoietin whenever possible. Always follow the national transfusion guidelines and document rationally why is this transfusion important to our patient. Just a 2-minute video regarding the 3 pillars of patient blood management.
Patient blood management is an evidence-based, multidisciplinary approach aiming to improve patient outcome and safety. Patient blood management spares and strengthens the patient's own resources, ensuring that you go into and out of surgery with more of your own blood. Patient blood management optimizes patient care in all medical fields. Whether in pediatrics or on the intensive care unit, patient blood management increases patient safety. That's because we focus on the individual patient. Patient blood management takes steps to screen for, prevent and treat anemia in order to protect your body. When you're with us, you're not just considered one of many. Your surgery is meticulously planned and tailored to suit you. Specialists of many disciplines collaborate in this, whether preoperatively, intraoperatively or postoperatively. Patient blood management focuses on 3 main aspects. First, if you suffer from anemia, we will recharge your energy level. We provide your body with the nutrients it needs for the formation of more blood, and we reduce the volume and amount of blood collection tubes required for diagnostic purposes to reduce losses. Second, the body's own resources are conserved thanks to meticulous blood-saving surgical techniques, the preparation and return of blood lost in the course of surgery, and the support of the blood clotting process. Your blood stays where it belongs, in your body. Third, the use of allogenic blood according to the latest scientific standards, according to the motto, transfusion of the right unit of blood to the right patient at the right time. Patient.
So, key takeaways from my perspective: verify patient and the blood product given meticulously, closely monitor during first 15 minutes of transfusion, that is when most of the transfusion reactions will be notified. Recognize and manage the reactions promptly. Do involve blood bank team also along with that to help you better understand the consequences of transfusion reactions, and use blood judiciously as per the patient blood management principles. Blood is a liquid transplant. Please order wisely. These are my references. Thank you so much.